Hello, hello, mic check. Hello, everyone. Okay. So, welcome to the discussion of today's session about the NEET PG 2024. This is PYQ, particularly involving the PYQs and the previous year topic questions for the revision of biochemistry topic. So, in this session, we will cover the mostly the important PYQs which are there in the NEET PG entrance examination. So it will cover the vitamin topic, main vitamins which are repeated most of the time. This includes the B1, that is thiamine. So it is VIP question or top rated question for NEET PG entrance examination. First one is the thiamine, second one is the niacin, then pyridoxal phosphate. Also there is question on the vitamin B12 and the folic acid. Okay, but these are the repeatedly asked topic, that is thiamine, because it includes number of the conditions, that is beriberi, Wernicke-Korsakoff psychosis. So it is overlapping topic with the psychiatry, that is Wernicke-Korsakoff psychosis. Niacin is overlapping topic with the skin, diarrhea, dermatitis, dementia is there. So also included in the psychiatry also. Pyridoxal, there is neurological manifestations. So these are the repeatedly asked topic or top rated questions in NEET PG entrance examination. Then second one is the mineral, which is important topic. That minerals, it includes particularly zinc and copper. There is also question on calcium, then question on the iron also, but zinc and copper, these are the frequently asked topic in NEET PG entrance examination. So in the vitamin, all vitamins and all minerals, they are important. The clinical conditions which are related with the vitamins and mineral, they are important for the uh, uh, for NEET PG entrance examination. Now, apart from this, the glycogen storage diseases, particularly McArdle disease, Pompe's disease, von Gog's disease, and newer one now in the previous NEET PG exam, there is question on glycogen synthesis. So this is important topic, that is glycogen storage disorders and the regulation of glycogen metabolism. Then hyperlipoproteinemias. This particularly includes type 1 and type 2A. Type 1 and type 2A, these are the important topics. This is hyperchylomicronemia, and here hypercholesterolemia. Here LDL and cholesterol increases, here TG level increases, there is risk of pancreatitis, here is the risk of coronary artery disease. So these are the important topics. Then Gaucho's disease. Gaucho's disease means the sphingolipidosis, they are important. Phospholipid and sphingolipidosis, this topic is important, particularly Gaucho's disease. So, there is no cherry red spot in the Gaucho on the retina in the Gaucho's disease, but there are disorders which is having the cherry red spot. Then hepatosplenomegaly and the refractory anemia, and the typical feature, the histological picture, pathological slide of Gaucho's disease, that is intracytoplasmic inclusion body, that gives the crumpled tissue paper appearance, which is important here. Crumpled tissue paper or wrinkled paper appearance, which is important here in the Gaucho's disease and sphingolipidosis. So this is important topic, and we'll discuss the, apart from this, we'll discuss the various PYQs in this session. Okay. I will start with the first, that is which is based on the integration of metabolism. The topic for this question is integration of metabolism and metabolism in starvation. So see, a diabetic patient had a meal at 9 p.m. and recorded blood glucose at 8 a.m. on the next day, which was 182 milligram per deciliter. What is the source of glucose in this patient? Now here the glucose is asked. See here, glucose, no, it is not energy which is asked, it is glucose. Okay, so source of glucose, see dietary glucose. So here answer is that is hepatic glycogenolysis. This is answer here, hepatic glycogenolysis. Now see, dietary glucose will provide the energy for 2 to 4 hours. Then hepatic glycogenolysis, it will provide the energy starting from the 4 hours to 16 hours. Then hepatic gluconeogenesis, it will start after 12 to 18 hours it will start. And the muscle glycogenolysis, it will not give you glucose. Remember this, muscle glycogenolysis. In muscle there is absence of the enzyme, that is glucose. Muscle, there is absence, there is no glucose 6 phosphatase. This enzyme is not there in the muscle. So in the muscle, the end product will be glucose 6 phosphate, and it will directly enter into the glycolysis. It will directly enter into the glycolysis. So there is no glucose in the muscle. So this is not answer here. Okay. So here answer is hepatic glycogenolysis, and liver will provide you the glucose, particularly starting from 4 hours to 12 to 16 hours. But these are not the strict guidelines कि 16 घंटे हो गए कि बटन बंद कर दिया, ऐसा नहीं रहेगा यहाँ पे. So it is overlapping, somewhat overlapping. Okay. So muscle will not provide you the free glucose here because of absence of this enzyme. That's why in von Gog's disease, what is von Gog's disease? There is glucose 6 phosphatase defect, means absence of glucose 6 phosphatase activity. That's why muscles are not involved in the von Gog's disease. Remember this. And this is common enzyme for the glycogenolysis, means breakdown of glucose 6 phosphate into the glucose. Also it is required for the gluconeogenesis. So it is important for both pathway, gluconeogenesis and glycogenolysis. So here answer is hepatic glycogenolysis. Now the next question, which of the following is most common repair associated with HNPCC? HNPCC means hereditary non-polyposis colorectal cancer. Now this is again repeat topic, repeatedly asked in the examination, particularly HNPCC, which is also known as Lynch syndrome. Lynch syndrome. And second one is the xeroderma pigmentosum. These are the two important topics from this DNA repair mechanism. Okay. So now these are the different types of DNA repair mechanism, and there are various diseases which are related with this type of mechanism. First we'll see the answer. Which of the following is the most common repair associated with Lynch syndrome or HNPCC, means hereditary non-polyposis colorectal cancer? So it is related with the mismatch repair. Here answer is mismatch repair. Methyl directed mismatch repair. When incorrect base is added, it is repaired with the help of mismatch repair mechanism, which is also known as methyl directed mismatch repair mechanism. Now it is involving the colon and rectum, and it is hereditary condition. It is also known as Lynch syndrome. And the second, see this nucleotide excision repair, it is related with the xeroderma pigmentosum. In this disorder there is thymine dimer formation. So this bulky lesion is removed by the xeroderma pigmentosum. Any repair mechanism, 4 basic steps are there. Recognition of the fault, matlab recognition. First step is the recognition. Second one is the removal. Third one is the synthesis with the help of polymerase, and fourth step is the ligation. So here nucleotide excision repair, it is related with the xeroderma pigmentosum and Cocaine syndrome. Then base excision repair, it is not important in case of disease. It is related with mute YH associated polyposis and homologous recombination repair. So this is double strand break repair. With this there are various diseases which are connected, that is Bloom syndrome, ataxia telangiectasia, then breast cancer susceptibility. So it is related with the double strand break repair, that is homologous recombination. But double strand break repair, for the double strand break repair, most common mechanism of repair is non-homologous end joining, and disorder which is related with non-homologous end joining is severe combined immunodeficiency. Now see this table, this is very, very important table. So these are the damaging agent which causes damage in the DNA, and this is a type of lesion which is caused by the DNA damage. Okay. Now these are the repair mechanisms. See, these are the 1, 2, 3, 4, 5 basic repair mechanism, which includes for the double strand break repair, particularly double strand. If there is break in the double strand of the DNA, means if there is break in the double strand of the DNA, it is repaired by two mechanisms. One is non-homologous end joining, which is most common in the mammals, and second one is the homologous recombination. So now this is caused by ionizing radiation, X-ray and anti-tumor drugs, and repaired by non-homologous end joining and the homologous recombination. In the non-homologous end joining, the two ends of the this break part of the DNA ligated directly without any recombination process. So direct non-homologous end joining. If there is a fault in the non-homologous end joining, it leads to the disorder that is known as severe combined immunodeficiency. The gene therapy was tried first on this disease, and this is due to adenosine deaminase deficiency, where T cell and B cell both are affected, and in this disease there is decrease in the uric acid level occurs. Okay. Now homologous recombination defect, it causes ataxia telangiectasia, that is ataxia telangiectasia like disorders. That includes ataxia means lack of coordination and the skin lesions. Okay. Bloom syndrome, which is characterized by the growth retardation, and the breast cancer susceptibility. So these are the diseases which are related with the homologous recombination. Nucleotide excision repair, if there is fault in the nucleotide excision repair, it will cause the xeroderma pigmentosum or the Cockayne syndrome. Xeroderma pigmentosum, there is multiple freckles or blistering skin lesions on the sun exposed part of the body. And if there is fault in the base excision repair, it causes mute YH associated polyposis. And if there is faulty mismatch repair, it causes hereditary non-polyposis colorectal cancer. So just wait. Hello everyone. Okay. See this question, identify E1 and E2 in the multi-enzyme complex involved in conversion of pyruvate to acetyl coenzyme A. इसका जो टेस्ट एंड डिस्कशन में पेपर था, इसका जो लास्ट ऑप्शन था वो इनकरेक्ट था. Okay, now see here, E1, E2, E3 in pyruvate dehydrogenase complex, there are three enzymes, तीन enzymes है जो ऐसे same है. One is the pyruvate dehydrogenase, second is the branch chain keto acid dehydrogenase, and third one is the alpha ketoglutarate dehydrogenase. Now here E1 in the pyruvate dehydrogenase complex is pyruvate dehydrogenase itself. Okay, तो ये भी चला जाएगा, ये भी चला जाएगा और ये भी चला जाएगा. So here the pyruvate dehydrogenase itself is the E1. Itself is the E1, and E2 is dihydrolipoyl transacetylase. This is important question, and it is frequently asked. The reason for this is this PDH complex which converts this pyruvate to acetyl coenzyme A. It requires 5 coenzymes. That's why it is frequently asked question. Now here 5 coenzymes are required. B1 means thymine is required. The thymine pyrophosphate is required. B2, FAD is required. Riboflavin, the FAD is the coenzyme form which is required. B3, niacin, that is NAD is required here in this reaction as a coenzyme. Then B5, coenzyme A is required. B5, and the lipomide. These are the required, means this is thymine pyrophosphate, this is FAD coenzyme form, this is NAD, then coenzyme A and the lipomide. These 5 coenzymes are required for this reaction, and as it is a irreversible reaction, the fat cannot give you glucose. The that is E1 chain fatty acid cannot give you glucose because of this irreversible reaction. The pyruvate is converted into acetyl coenzyme A. So it is multi-step process in which first step pyruvate is decarboxylated with the help of PDH. So here see, pyruvate, it decarboxylated in the first step, then The thymine pyrophosphate accept the hydroxyethyl group. It is converted into hydroxyethyl thymine pyrophosphate. Then the lipomide, oxidized lipomide, it is converted into acetyl lipomide, and it is converted into reduced form of the lipoic acid, that is reduced lipomide. So here the coenzyme sulfidyl group, reduced form of the coenzyme A, then there is formation of acetyl coenzyme A. Okay, and here the FAD and NAD it is required. तो यहाँ पे जगह नहीं है इसलिए मैं निकालता नहीं. Now see E1, here E1 is the pyruvate dehydrogenase complex itself. E2 here, E2 is dihydrolipoyl transacetylase, dihydrolipoyl transacetylase, and here E3 is dihydrolipoyl dehydrogenase, E1 E2 E3 ऐसे 3 एंजाइम्स है. पहला PDH कॉम्प्लेक्स, दूसरा अल्फा कीटोग्लूटारेट कॉम्प्लेक्स, that is alpha ketoglutarate dehydrogenase, and third one is branch chain keto acid dehydrogenase complex. So ये important topic है thymine pyrophosphate. Energetics in this step, it is 5 ATPs per molecule of glucose. For one conversion of pyruvate to acetyl coenzyme A, it is 2.5 ATPs. Okay. Which vitamin is deficient in the patient presenting with diarrhea, dementia, dermatitis and maize being his staple diet? ये तो important question है, repeatedly आता है. नियासिन मैंने पहले भी बोला आपको कि your drug of choice. Hi Rahima Nazir. Hi Dr. Jain. Hi Sakshi. Hi Praveen. Answer D is correct answer. Diarrhea, dementia, dermatitis, classical 3 Ds. If untreated, 4th D is there, that is known as death. Okay, diarrhea, dementia, dermatitis. Diarrhea, लॉस ऑफ मेमोरी एंड डर्मेटाइटिस, ये कैसल्स नेकलेस पे काफी बार क्वेश्चन आया है. सो अराउंड द नेक, अराउंड द सन एक्सपोज पार्ट ऑफ द बॉडी देर इज डर्मेटाइटिस. sun exposed part of the body there is dermatitis, and particularly also involving the hand, like glow and stalking appearance of hand and feet. So dermatitis, it is typical, it is known as Castle's necklace. So Castle's necklace dermatitis, it is important here in the niacin, means the pellagra. The name of the disease is pellagra. Particularly pellagra, it is there are different conditions which can cause pellagra like symptoms, because it is connected. Some part of the niacin, it is synthesized from the amino acid. It is synthesized from the amino acid tryptophan. It is endogenously produced vitamin, but not the 100% it is produced. Some 10% it is produced from the tryptophan. So from tryptophan, niacin is produced. So tryptophan will give you NAD, NADP, and for this conversion you require the pyridoxal phosphate is required in this conversion. Also for this conversion, the tryptophan kynureninase enzyme is required. For the kynureninase activity, pyridoxal phosphate is required for conversion of tryptophan to NAD. So if there is pyridoxal phosphate deficiency, it can also cause the pellagra like symptoms, means this classical 3 Ds, that is diarrhea, dementia, dermatitis. Also it is common in maize and jowar eating population. What is the reason? Maize, the niacin, it is present in bound form, so it is unavailable for the absorption in the maize eating population, while jowar, it has high leucine content. This jowar has high leucine content, and because of high leucine content, it inhibit the enzyme QPRTase, quinolinate phosphoribosyl transferase, which is important here in the NAD synthesis, which is important here in the NAD tryptophan to NAD synthesis. So in the B6 deficiency, that is pyridoxal phosphate deficiency, there is deficiency of niacin occurs. Also in maize and jawar eating population, the deficiency occurs. Also in the carcinoid syndrome. Carcinoid syndrome. So carcinoid syndrome, the tryptophan, it is diverted for the serotonin production. 60% tryptophan is diverted for the serotonin production. So there is deficiency of niacin occur. Also in the heart nerves disease, where tryptophan absorption, neutral amino acid absorption is decreased, in that disease also there is deficiency of द नियासिन ऑकर. सो ये सब एक जगह पे जब आता है, मतलब हार्ट नर्व्स डिसीज, कार्सिनाइड सिंड्रोम, B6 deficiency, जवार ईटिंग पॉपुलेशन, मेज ईटिंग as a staple diet, it causes the niacin deficiency. The nutritional deficiency is the most common cause that causes the diarrhea, dementia and dermatitis. Thiamine deficiency causes beriberi. Beriberi means weakness. There are three main types of beriberi: dry, wet and the infantile beriberi. Apart from this, thiamine is important for the Wernicke-Korsakoff psychosis in chronic alcoholic. That's why it is important. Riboflavin deficiency causes the circumoral and circumcorneal manifestation. So it is angular stomatitis, cheilosis, glossitis. Then the pink eye, the conjunctivitis or pink eye, seborrheic dermatitis. These are the symptoms of riboflavin deficiency. Pyridoxine deficiency, pyridoxal phosphate, the one of the important function of pyridoxine apart from the transamination is decarboxylation and synthesis of neurotransmitter. So pyridoxine deficiency causes the neurological symptoms, that is convulsion seizures. Okay, that causes convulsion seizure. And pyridoxine, it is important, and the deficiency of pyridoxine will be there when we give the INH, isoniazid therapy, for the treatment of tuberculosis. Vitamin needs to be supplied in the diet of patient with cystathionine beta synthase defect. थोड़ा घुमा के पूछा है. होमोसिस्टीन यूरिया पूछा रहता तो आपको थोड़ा इजी गया रहता. होमोसिस्टीन यूरिया, दिस इज बिकॉज ऑफ डेफिशिएंसी ऑफ cystathionine beta synthase enzyme. So what is answer here? What should be answer here? It's not leucine. Hi Vakar. Hi Sai. Yes, correct. A is the answer. A is the answer here. Cysteine. Why cysteine is the answer here? So for that आपको उसके लिए इसका थोड़ा सा पाथवे पता चाहिए, और ये पाथवे याद करना ही पड़ता है. क्यों याद करना पड़ता है? क्योंकि ये B12 के साथ रिलेटेड है, ये फोलिक एसिड के साथ रिलेटेड है, ये मिथ्योनिन सिस्टीन मेटाबॉलिज्म से रिलेटेड है, ये होमोसिस्टीन यूरिया से रिलेटेड है, इसलिए ये पाथवे इंपॉर्टेंट है. नाउ सी दिस पाथवे एंड ऑलवेज रिमेंबर पाथवे इन दिस डायरेक्शन. ओके, ये जो डायरेक्शन हम निकालते ये इंपॉर्टेंट है. नाउ सी हियर, methionine in this pathway, methionine is converted into S-adenosyl methionine, which is a universal methyl group donor. S-adenosyl methionine. Now this S-adenosyl methionine is converted into S-adenosyl homocysteine, and this is a transmethylation reaction where methyl group is accepted by an acceptor and it is converted into methylated product. For example, epinephrine. For example, so norepinephrine is converted into epinephrine. Norepinephrine, no methyl group. Norepinephrine means no methyl group. Remember this. So S-adenosyl methionine is converted into S-adenosyl homocysteine, and S-adenosyl homocysteine by S-adenosyl homocysteinase, it is converted into homocysteine. Now see, this is important. Homocysteine. Now homocysteine is converted into methionine. It is converted into methionine, and for this reaction B12 is required, and in this reaction methyl tetrahydrofolate is converted into tetrahydrofolate. So this is folate trap reaction. If B12 is deficient, it causes the trapping of folate in the form of methyl tetrahydrofolate, जिसका कोई दूसरा काम नहीं है. तो ये अवेलेबल भी रहता लेकिन कुछ काम का नहीं रहता, इसलिए इसको बोलते हैं फंक्शनल फोलेट ट्रैप. क्या बोलते हैं? फंक्शनल फोलेट ट्रैप. सो ये तो एकदम इंपॉर्टेंट है सल्फर कंटेनिंग अमाइनो एसिड के मेटाबॉलिज्म में, क्योंकि B12 और फोलिक एसिड दोनों यहाँ पे एक दूसरे से related है, that is known as folate trap. Now this homocysteine, it is converted into cystathionine, and cystathionine, it is converted into cysteine plus homoserine. Here homocysteine plus serine is there. Okay, so there is enzyme, the name of the enzyme is cystathionine beta synthase. And this is pyridoxal phosphate dependent reaction, vitamin B6. Also this one, cystathioninase. This is also pyridoxal phosphate dependent reaction. Now, if there is block in this cystathionine beta synthase, if there is block here, there is elevated level of homocysteine occur, there is elevated level of methionine occur, but there is decreased level of cysteine. So this will decrease. So it has to supplied in the diet. Cysteine has to supplied in the diet, but there is increased methionine level, there is increased homocysteine level, and homocysteine causes cardiovascular disorder. It causes atherosclerosis, homocysteine, increased homocysteine level, because it interferes with the collagen cross links, leads to the formation of reactive oxygen species that forms the oxidized LDL, and oxidized LDL is responsible for the plaque formation. So in that way, homocysteine causes the cardiovascular diseases. So here cysteine has to be supplied in the diet because there is decreased cysteine. So this is classical homocysteine urea cystathionine beta synthase, which is pyridoxal phosphate dependent enzyme. Got it? So this is important. Homocysteine urea is the important topic. Now this is again very important topic, और हर एग्जाम में, जैसे मैं आपको बोला कि स्पिंगोलिपिडोसिस आपको सारे पढ़ने हैं, आपको हाइपरलाइपोप्रोटीनेमिया सारे पढ़ने हैं, आपको ये रिपेयर वाला टेबल आपको पूरा पता चाहिए, रिपेयर वाला टेबल, न्यूट्रिशन का जो RQ और SDA वाला टेबल है वो भी पूरा पता चाहिए. सी मल्टीपल टेंडॉन ज़ैंथोमास, जब ये वर्ड आता है टेंडन, तभी हमारा डायग्नोसिस होना चाहिए, पहला प्राइमरी डायग्नोसिस. मल्टीपल टेंडॉन ज़ैंथोमास वेयर फाउंड इन ए पेशेंट on evaluation serum cholesterol, see cholesterol 401 milligram per deciliter and LDL 218 milligram per deciliter were found to be raised. Patient was प्रिस्क्राइब्ड statins. Statins क्यों देते? कोलेस्ट्रॉल कम करने के लिए देते. इट इज ए कॉम्पिटेटिव इनिबिटर ऑफ HMG coenzyme reductase. What is the probable diagnosis? So what is answer here? Ketan Raj, Sakshi B. B is the correct option. Bharat B. Sai B. You were a drug of choice. अरे आपका नाम डालो ना यार, you were a drug of choice, कैसे लगता? So here answer is familial hypercholesterolemia. एकदम सिंपल है यहाँ पे. सी एकदम सिंपल है यहाँ पे. मैंने क्या बोला आपको? दो ही डिसीजेस याद रखो हाइपर लाइपोप्रोटीनेमिया में, अच्छे से दो ही याद रखना है. पहला तो टाइप 1 और दूसरा टाइप 2A. दिस इज टाइप 2A बिकॉज देर इज टेंडॉन xanthoma, then raised cholesterol, raised LDL. Because of raised cholesterol, statins are given here in the treatment. So it is a case of familial hypercholesterolemia. Tangiers disease तो एकदम typical रहता है. It is orange colored swollen, orange color, red orange color tonsil बोला तो Tangiers disease, and decrease HDL level बोला तो Tangiers disease. Okay, ये next table ये बताता मैं. See, if there is cholesterol increase, there is clinical finding will be tendon xanthoma, means xanthomas or tubercle like lesions on the tendons, affecting the tendons, particularly tendo Achilles or tendon of the larger muscles, they are involved. So tendon xanthomatitis in the type 2A. And when there is increased cholesterol, there is increased risk of coronary artery diseases. एथेरोस्क्लेरोसिस होगा, इसलिए उसमें coronary artery diseases की रिस्क रहेंगी. Now if there is increase in the TG, it causes eruptive xanthomas. ऐसे येलो कलर के ऐसे papules टाइप या ऐसे nodular और papular lesions रहेंगे. So that is eruptive xanthomas, and it can be there in the type 1, type 4, type 5. Okay, if there is a raised chylomicron level, and chylomicron gives turbidity to the serum, if we collect the serum of the patient, ब्लड अगर कलेक्ट किया तो इट इज लाइक मिल्की प्लाज्मा, पूरा टर्बिड रहेगा. So it indicates there is increase in the chylomicron level. So it indicates the type 1 hyperlipoproteinemia type 1. And yellow orange color tonsil अगर है, HDL लेवल अगर लो है, that indicates the Tangios disease. तो इतना बड़ा टेबल है, लेकिन इतना बड़ा ये टेबल याद करने की जरूरत नहीं है. जस्ट रिमेंबर 1 and 2A, 1 and 2A देयर डिफेक्ट, ये भी बार बार पूछा जाता है, देयर डिफेक्ट. एंड ऑल्सो टाइप 4 में ये याद रखना है सिर्फ इंसुलिन resistance means hyperinsulinemia. There is hyper glucose tolerance and hyperinsulinemia in the type 4. Now see, in the type 1 there is increase in the chylomicron level, there is increase in the VLDL level, there is milky plasma. In clinical feature there is eruptive xanthomas, and because of raised triacylglycerol in the type 1 there is risk of pancreatitis, and it is because of lipoprotein lipase deficiency or ApoC2 defect. ApoC2 defect. And familial hypercholesterolemia, there is increased LDL, there is increased cholesterol, there is tendon xanthoma, there is increased risk of atherosclerosis and coronary artery diseases. So it is due to LDL receptor defect or ApoB100 defect. And type 4, that is familial hypertriglyceridemia, it is associated with glucose intolerance and hyperinsulinemia. ये 3 पॉइंट स्पेसिफिकली याद रखो, पर्टिकुलरली सब याद रखो, क्योंकि एक टॉपिक पे अगर क्वेश्चन आता है तो वो टॉपिक पे रिपीटेडली क्वेश्चन आता है. बट लेकिन ये जो चीज़ें टाइप 1, टाइप 2A एंड टाइप 4, ये आपको याद रखना है. एंड द इन हाइपोलाइपोप्रोटीनेमिया, ये तो हाइपर के कॉजेस हो गए, इसको बोलते हैं फ्रेडरिक्सन क्लासिफिकेशन. हाइपो के कॉजेस है अबीटा, मतलब जिसमें बीटा लाइपोप्रोटीन बनेगा नहीं. अगर बीटा नहीं बनेगा मतलब VLDL नहीं बनेगा, LDL नहीं बनेगा, और काइलोमाइक्रोन नहीं बनेगा, क्योंकि इसमें B48 रहता है, इसमें B100 रहता है, इसमें B100 रहता. Then Tangios disease, it is due to mutation in ABCA1 transport protein, that is ATP binding cassette transporter, that is ABCA1. What is function of this protein? It is important for carrying the cholesterol from peripheral tissues to the discoidal HDL, so that HDL, after esterification of this cholesterol, HDL becomes spherical. So it is important in the reverse transport of cholesterol and synthesis of the mature HDL. Okay. So low levels of HDL and ApoA1 is there in the Tangios disease, and this is a classical picture, that is enlarged yellow color tonsils. Also peripheral neuropathy will be there in Tangios disease. So this is important in the lipoproteinemia or hyperlipidemia. Again the next important topic, और ये डायग्राम थोड़ा घुमा फिरा के क्रम्पल टिश्यू पेपर, रिंकल्ड पेपर अपीयरेंस ये रहती है एग्जाम में, मैक्सिमम टाइम रहती है. So a patient came with complaint of weakness and bony pain. On evaluation, anemia and hepatosplenomegaly was detected. Below is the histological picture showing cells in the bone marrow. Which of the following enzyme is deficient? Also, this is overlapping or integrated topic with the pathology. So this is very, very important. Okay. So here see, this is crumpled tissue paper, tissue paper or wrinkled paper appearance. तो यहाँ पे 2-4 फाइंडिंग्स है जो स्पिंगोलिपिडोसिस में बहुत इंपॉर्टेंट है, जैसे कि क्रम्पल टिश्यू पेपर अपीयरेंस ऑफ द मैक्रोफेजेस, देन एर्लेनमेयर फ्लास्क डिफॉर्मिटी, जिसमें कि एक्सरे में जो फीमर का लोअर एंड है वो ऐसे फ्लास्क जैसे दिखता है, वैसे फ्लास्क जैसे रहता है ना, वैसे लोअर एंड ऑफ फीमर इज लाइक, दैट इज नोन एज एर्लेनमेयर फ्लास्क डिफॉर्मिटी. और इसमें स्पिंगोलिपिडोसिस में और एक फीचर है, दैट इज द चेरी रेड स्पॉट ऑन द मैक्युला, जो इसमें नहीं रहता, जो KGF में नहीं रहता. KGF मतलब क्रेबेज डिसीज, गाउचोस डिसीज एंड फैब्रीज डिसीज, ये तीनों में छोड़ के बाकी इसमें जनरली चेरी रेड स्पॉट ऑन द मैक्युला इज देयर. ओके. सो दिस इज हियर आंसर इज, व्हाट इज आंसर हियर नाउ? टेसेक नहीं है, गाउचर तो है, मैंने पहले तो बोला क्रम्पल टिश्यू पेपर अपीयरेंस. सो गाउचर में कौन सा रहता है? Gaucher's disease, which enzyme is deficient in the Gaucher's disease? See, this is glucose 6 phosphatase, it is von Gerg's disease. Okay. Hexosaminidase A, it is Tay-Sachs. glucocerebrosidase, and beta galactosidase, this is Krabbe's. This is answer, glucocerebrosidase. Yes, correct. See, glucocerebroside. Cerebroside मतलब क्या होता है? Fatty acid. Cerebroside means it is ceramide. Ceramide means fatty acid plus sphingosine. Sphingosine मतलब amino alcohol. When fatty acid attached with the sphingosine, it is known as ceramide. And when ceramide is when to this ceramide glucose is attached, it is known as glucocerebroside. And when galactose is attached, it is known as galactocerebroside. When oligosaccharide is attached, it is known as the globoside. And when oligosaccharide containing NANA, N-acetylneuramic acid is there, it is known as the ganglioside. Like that, the naming is done in the glycosphingolipids. So here glucocerebroside, because of here enzyme glucocerebrosidase. So this is glucocerebrosidase is absent, and which is important for breakdown of glucocerebroside. So glucocerebrosides accumulates in the macrophages, causes the wrinkled tissue paper appearance. So these are the different enzymes and these are the accumulated products. So here in this chart, this Gaucher is important. So here glucocerebrosidase or beta glucosidase is deficient. In the Niemann-Pick disease, it is sphingomyelinase which is deficient. Krabbe's disease, beta galactosidase. Fabry's disease, alpha galactosidase. Then Tay-Sachs disease, hexosaminidase A, and Sandow disease, hexosaminidase A and B. Now, the characteristic feature to remember how to solve the clinical case in the examination. See here, in the Gaucher's disease, there is no cherry red spot. No cherry red spot. No cherry red spot in the Gaucher's disease. There is wrinkled tissue paper macrophages, means tissue paper macrophages, wrinkled paper macrophages or crumpled tissue paper macrophages are there in the Gaucher's disease. Then in Gaucher's disease, it involves bone, liver, and the spleen. They are involved, and there is cell count decreases, means WBC, RBC, platelet all decreases. So there is refractory anemia in the Gaucher's disease. Also, because of decrease in the platelet count, there is thrombocytopenia and easy bruising is there in the Gaucher's disease. So Gaucher disease particularly involving the bone, bone marrow, liver and spleen, they are involved in the Gaucher's disease. Bone, there is Erlenmeyer flask deformity in the Gaucher's disease. Remember that there is no cherry red spot on the macula in the Gaucher's disease. Niemann-Pick disease, there is cherry red spot on the macula and the hepatosplenomegaly is there. Niemann-Pick disease, sphingomyelin is affected, there is accumulation of sphingomyelin. So hepatosplenomegaly is the feature. Then cherry red spot on the macula is there in the Niemann-Pick disease. Then in the Fabry's disease, there is this is GM1 gangliosidosis and there is telangiectatic skin lesion, that is known as angiokeratomas are there in the Fabry's disease. Tay-Sachs disease, this is in the Tay-Sachs disease, organs are not involved. There is neurological involvement in the Tay-Sachs disease, but and also there is cherry red spot on the macula, but organs are not involved. So no organomegaly is there in the Tay-Sachs disease. It is due to hexosaminidase A defect. It is GM2 gangliosidosis. There is accumulation of GM2 gangliosides. And Sandow disease, there is organomegaly with the features of Tay-Sachs disease. So these are the point to remember in the sphingolipidosis. So if these enzymes are defective, which are responsible for breakdown of these sphingolipids, that they can accumulate and they cause the disease. For example, see beta galactosidase. For the breakdown of galactocerebroside, beta galactosidase is required. If it is defective, so galactose means this galactocerebroside will accumulate. Similarly, see this is Gaucher's disease, beta glucosidase, which is responsible for breakdown of glucocerebrosides. If this is defective, it will accumulate glucocerebroside in the tissues like that. So this is very common from the glycosaminoglycan. All properties, means the distribution, their composition and their functions are very, very important, glycosaminoglycans. So cornea is transparent, its endothelium is maintained by. For the corneal transparency, keratin sulfate 1 and dermatan sulfate is important. So if it is keratin sulfate in the option, it is answer. If keratin sulfate is not there in the option, dermatan sulfate is the next best option. Okay, so here keratin sulfate is the answer. Okay. Now what are the uses of heparan sulfate? क्या काम है heparan sulfate का? Yes, D is the correct answer. What is the function of heparan sulfate in our body? इसके जो function है वो important है MCQ के लिए. Hyaluronic acid का distribution, it is distributed in the synovial fluid and vitreous humor of the eye. Then hyaluronic acid along with the chondroitin sulfate is important for compressibility of cartilage in the weight bearing joint. Okay, keratin sulfate 1, it is a constituent of the cornea and it is responsible for the corneal transparency. Heparan sulfate, main important function of heparan sulfate is it is required for attachment of lipoprotein lipase. Here answer is keratin sulfate. So attachment of lipoprotein lipase enzyme to capillary endothelium, this is required. And second, it is present in glomerular basement membrane and it is important for negatively charged glomerular basement membrane because because of negative charge of glomerular basement membrane, so albumin despite of the low molecular weight does not crosses the glomerular filtration barrier because of negative charge which is carried by the heparan sulfate. If there is loss of charge that occurs in the glomerulonephritis nephrotic syndrome, albumin appears in the urine. Hyaluronic acid, it is important for the wound repair. It is distributed in the synovial fluid and vitreous humor of the eye. It acts as a shock absorbent and lubricant. Chondroitin sulfate along with the hyaluronic acid is important for the compressibility of the cartilage. Next one is the heparin, which is anticoagulant. Now remember in this glycosaminoglycan, keratin sulfate is one who do not contain uronic acid. Keratin sulfate does not contain uronic acid. See, next question. A patient in his mid-20s complained that his urine is very dark. Urine is very dark in color and blackens on exposure to air. So this is a characteristic feature. What is the enzyme defect in this case? So इससे अभी मुझे ABCD मत डालो, आप लोग इसका डायग्नोसिस डालो. यूरिन स्टैंड डार्क मीन्स यूरिन टर्न डार्क ऑन स्टैंडिंग. हाँ, अभी अभी इसका आंसर सबको पता है. हाँ, अभी देखो इसमें, अभी इसका आंसर डालो मुझे. हाय भरत, हाय यूर ड्रग ऑफ चॉइस. नाम डालो अपना. हाय वकर. वही तो बोल रहा मैं, आपको डायग्नोसिस पता है लेकिन आपका आंसर यहाँ पे गलत हो रहा है. सी, मैं एक आपको बताता. दिस इज फेनिलैलानिन. This is phenylalanine. It is converted into para-hydroxyphenylalanine. That is the another name for tyrosine. Phenylalanine is converted into tyrosine, means para-hydroxyphenylalanine. Now this para-hydroxyphenylalanine is converted into para-hydroxyphenylpyruvate. Okay. Now this para-hydroxyphenylpyruvate, it is converted into para-hydroxyphenylacetate. पैराहाइड्रोक्सीफेनिल एसिटेट. अभी इसका पैराहाइड्रोक्सीफेनिल एसिटेट इस पे जो एक्ट करेगा, अभी इसके दूसरे नाम भी लिखता है आपको, थोड़ा सा इजी जाएगा. सो फेनिलैलानिन इज कन्वर्टेड इनटू टायरोसिन. टायरोसिन इज कन्वर्टेड इनटू पैराहाइड्रोक्सीफेनिल पायरुवेट and para-hydroxyphenyl pyruvate is converted into para-hydroxyphenyl acetate, that is known as homogentisic acid. Which is converted into 4-mallyl acetoacetate, then 4-fumaryl acetoacetate, and it is converted into fumarate and acetoacetate. In that way it is give glucose and fat both. So phenylalanine and tyrosine will give both glucose and fat. Now see here. So here answer is phenylalanine hydroxylase. तो आंसर है नहीं, क्योंकि ये दिस विल कॉज द फिनाइल कीटोन यूरिया. ओके, fumaryl acetoacetate hydrolase. This is not the case. It will cause tyrosinemia type 1 first. FF fumaryl acetoacetate hydrolase first. तो ये दो आंसर कट गए, अभी ये दो बचते हैं. होमोजेंटिसेट डिहाइड्रोजनेज नाम का कोई एंजाइम नहीं है. होमोजेंटिसेट डाइऑक्सीजनेज चाहिए हमको. हमको क्या चाहिए? होमोजेंटिसेट डाइऑक्सीजनेज या होमोजेंटिसेट ऑक्सीडेज, ये नाम चाहिए आपको. लेकिन ये यहाँ पे है ही नहीं डिहाइड्रोजनेस, तो ये भी चला गया. नाउ रिमेनिंग दिस फेनिल एसिटेट डाइऑक्सीजनेस, इसका ही नाम दूसरा ये है, बट इट इज पैरा हाइड्रोक्सी फेनिल एसिटेट डाइऑक्सीजनेस इज द आंसर. पैरा हाइड्रोक्सी फेनिल एसिटेट डाइऑक्सीजनेस इज द आंसर. ये सब ना इसके दूसरे दूसरे नाम होने की वजह से. फेनिलएलानिन इज कन्वर्टेड इनटू टायरोसिन, मींस पैराहाइड्रोक्सी फेनिलएलानिन. कुछ नहीं, पैरा पोजीशन पे एक OH लग जाता, इट बिकम्स टायरोसिन. Okay, now tyrosine is converted into para-hydroxyphenyl pyruvate, and para-hydroxyphenyl pyruvate into para-hydroxyphenyl acetate, which is converted into 4-methyl acetoacetate. So homogentisate oxidase, it is another name, that is para-hydroxyphenyl acetate dioxygenase. Okay, so here answer is A. Here answer is A. मतलब इतना इजी क्वेश्चन आके भी हमारा गलत हो गया क्योंकि हमको ये नाम नहीं पता थे उसके. ठीक है, सो आंसर इज A. A researcher isolated mitochondria and put in a medium containing succinate, fumarate, ADP and inorganic phosphate. ATPs were produced. Later, a compound was added and oxidative phosphorylation was decreased. So, oxidative phosphorylation was decreased. What's that compound? Okay, just wait. Just wait. आंसर बताओ चलो. See, later a compound was added and oxidative phosphorylation was decreased. So यहाँ पे मेंशन ही किया है oxidative phosphorylation. So oxidative phosphorylation को इनहिबिट कौन करता है? See, antimycin, it is inhibitor of complex 3 of electron transport chain. 2,4 this is not answer. 2,4-dinitrophenol, it is the uncoupler. Oligomycin, inhibitor of oxidative phosphorylation, and rotenone is the inhibitor of complex 1 of electron transport chain. So here answer is oligomycin. It inhibit FO F1 complex. Okay, so oligomycin is answer here. तो ये सब पूरा टेबल आपको पता चाहिए, कौन से इनिबिटर है, कौन से अनकपलर है. आगे भी इससे रिलेटेड एक क्वेश्चन है तो उसमें वो टेबल डाला हुआ है. तो वो आपको कॉम्प्लेक्स 1, कॉम्प्लेक्स 2, कॉम्प्लेक्स 3, कॉम्प्लेक्स 4 के इनिबिटर्स, अनकपलर्स के एग्जाम्पल और पोटेशियम आइनोफोर्स, ये आपको याद रखने हैं यहाँ पे. SDA स्पेसिफिक डायनामिक एक्शन और थर्मिक इफेक्ट ऑफ फूड, इट इज मैक्सिमम फॉर प्रोटीन्स. फॉर प्रोटीन्स it is 30%. It is 30% for protein. It is 0 to 5% for lipid and 5 to 10% for the carbohydrate, and for the mixed diet it is 10%. So extra calorie required over and above the calorific value of the food. For example, for the protein, so for the energy which is required for conversion of protein into urea, then transamination reaction, then transport of this. Particularly, initially it was said that it is required for the digestion, absorption and metabolism of the compound. So in case of protein, it is much more. So this should be kept in the mind while calculating the energy requirement of the food. So SDA of the SDA is maximum for the protein. This is again important question. Then see this image, this is important and very famous image. Okay, so self mutilating activity is there. So a mother came to OPD with 14-year-old mentally retarded boy, complaining of joint pain, irresistible urge to bite his finger and lips. The serum uric acid level was found to be elevated, uric acid raised. Mention the defective pathway related to above mentioned condition. So this is defective pathway ask here, not the disease. So this is what is the name of this disease? What is the name of disease? Yes, correct. Answer is correct. What is name of disease? क्योंकि हमको ऐसे का ऐसा रिपीट नहीं होगा ना, क्वेश्चन आएगा तो टॉपिक रिपीट होगा, उसमें से डिसीज पूछेंगे, उसमें एंजाइम का डिफेक्ट पूछेंगे, कौन सा पाथवे इन्वॉल्व, व्हाट इज द नेम ऑफ डिसीज, self mutilating activity, mental retardation, raised uric acid level. What is the name of disease? The name of disease is Lesch-Nyhan syndrome. It is Lesch-Nyhan syndrome, and it is due to defect in the enzyme HGPRTase, hypoxanthine guanine phosphoribosyl transferase. Hypoxanthine guanine phosphoribosyl transferase. The purine salvage pathway is affected here in this. See this purine salvage pathway where nitrogen bases are directly converted into nucleotide with the help of hypoxanthine guanine phosphoribosyl transferase. If there is block, if there is block in this enzyme or decreased activity of this enzyme, there is increased level of PRPP which is diverted. This PRPP, it is diverted for the de novo purine synthesis, and degradation of the purine nucleotide causes increases the uric acid level. Also brain and RBCs, they are dependent on the nucleotides which are produced by the purine salvage pathway. So decreased nucleotide synthesis that causes the neurologic, this is thought to be cause for the neurological manifestation in the Lesch-Nyhan syndrome. Next question, a tourist visited Africa where he developed malaria. See, remember, whenever there is malaria and primaquine therapy, suspect the disease, that is G6PD deficiency. Whenever any drug therapy is there and hemolytic anemia or hemolytic disease is there, suspect the G6PD deficiency. It is quite common. Say a tourist visited Africa where he developed malaria. He was treated with primaquine. So primaquine is the therapy which is given anti-malarial drug, and later develop hemolytic anemia. Deficiency of enzyme involved in which of the following pathway could be the cause? So it is involved in which pathway? G6PD. कौन से pathway में involved है G6PD? So इसी से related है, इसी को घुमा के 2-3 क्वेश्चन करते हैं. एक आधे बार ड्रग से रिलेटेड पूछेंगे, फार्मा में जाएगा क्वेश्चन. यहाँ पे अभी पाथवे पूछा है, नहीं तो डेफिशिएंट एंजाइम का नाम पूछेंगे, या ऐसा कुछ तो भी मतलब चेंज करेंगे, या पाथवे के प्रोडक्ट्स पूछेंगे. HMP shunt. So it is HMP shunt, hexose monophosphate shunt, G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency. So there are four enzymes which produce NADPH. So here 2 are there from the HMP shunt, that is G6PD, glucose 6-phosphate dehydrogenase, and phosphogluconate dehydrogenase. Phosphogluconate dehydrogenase. These are the 2 enzymes from the HMP shunt which will give you 60% of NADPH. Rest of the NADPH, it is given by the NADP malate dehydrogenase, that is malic enzyme, NADP malate dehydrogenase, and the cytosolic isocitrate dehydrogenase. These are the sources for NADPH. Now, when NADPH is less produced, as in the G6PD deficiency, there is less production of NADPH. What is the prime function of NADPH? It is antioxidant. It is required for the antioxidant activity. When there is oxidant drug, primaquine, acetinilamide, primaquine, then that is sulfonamide, or also pivabins, they causes the generation of reactive oxygen species in absence of this NADPH, and this reactive oxygen species damage the RBC membrane that causes the hemolytic anemia. So this is related with the HMP pathway. So remember, so autosomal recessive inheritance pattern is seen in, अभी इसमें से ना cystic fibrosis हर एक को पता है, maximum लोगों को. It is due to mutation in the CFTR gene, that is cystic fibrosis transmembrane regulator gene, where the chloride channels are affected, and it is autosomal recessive disorder. These are the autosomal dominant disorders. Transport of fatty acid across the inner mitochondrial membrane is carried out by कौन से 2 एंजाइम्स है? कार्निटिन असाइल ट्रांसफरेज 1, कार्निटिन असाइल ट्रांसफरेज 2, outside the membrane and the inner mitochondrial membrane. It is carnitine which is responsible for transport of fatty acid. So remember the carnitine shuttle system, which is important for transport of fatty acid across the inner mitochondrial membrane. Which of the following mutation in the nucleotide base pair result in termination codon? So termination codon, this is known as nonsense mutation. Nonsense mutation. Particularly remember this thing, the mutation related thing in case of sickle cell anemia, which is example of missense point mutation. It is transversion type of point mutation in the sickle cell anemia. Sickle cell anemia is the autosomal recessive disorder. And just see the pattern of inheritance in the autosomal recessive disorder, where both the parents are the carrier. There are chances of having the carrier is 50%, 25% chance of having the affected child, and 25% chance of having the normal child. So that is the missense mutation, that is partially acceptable missense mutation, sickle cell anemia. Okay, here the termination codon, that is the nonsense mutation. Which of the following is involved in DNA packaging? So DNA packaging, which proteins are involved, which are the basic proteins which forms the octamer, and around the octamer DNA will be supercoiled, 1.75 fold of superhelical DNA around the histone octamer protein. So these are important in organization of DNA. So around this histone octamer, that is H2A, H2B, H3, H4. So this total 8 molecules are there, means H2A, H2B dimer and H3, H4 tetramer. Around these histone proteins, around this there is superhelical fold of DNA, 1.75 fold of DNA, which includes near about 145 to 150 nucleotides or 150 base pairs, separated by the linker DNA molecule which contain H1 histone, and H1 histone is known as the linker molecule which spans about 30 base pairs. So this is important for the formation of nucleosome, which gives 10 nanometer fibril. Now see, this is 2 nanometer DNA, which is by forming the nucleosome, that is bits on string appearance wrapping around the nucleosome along the histone octamer, it will form 10 nanometer chromatin fibril, which is converted into 30 nanometer fiber, which contains 6 to 8 nucleosomes. Supercoiled structure, 6 to 8 nucleosome. This 330 is converted into 300 and 700. These are the nuclear scaffold associated form, that is known as 300 and 700 nanometer, and which is converted into 1400 metaphase chromosome. So there is 10 to the power 4-fold decrease in the length of DNA, while packaging into the nucleus. So 2-meter DNA fits into a cell of 2 micrometer size. So this is because of DNA packaging with the help of major and minor grooves of the DNA, which associates with the histone protein. So this is important in the organization of DNA. Now remember, histone proteins H2A, H2B, H3, H4, there are in the octamer, the core histone, and the H1 is known as the linker DNA molecule. So it is reached in the basic amino acid which interacts with the DNA. Now this is important, you should be able to identify the acid base disorder, and this is very important condition. It is related with carbohydrate metabolism, it is related with the ketone body metabolism, it is related with the arterial blood gas analysis. That's why it is important. 17-year-old boy diagnosed with diabetes. 17-year-old matlab diabetes matlab it is type 1 diabetes mellitus, was brought to the hospital in semi-conscious state and abnormal deep rapid breathing, means Kussmaul respiration is there. His plasma glucose was 673 milligram per deciliter. Urine shows positive Benedict test and the Rothra's test. Rothra's test means ketone bodies are there. Purple ring. So blood investigation reveals following result. Blood pH is 7.21. 7.21 means decrease, means acidosis. Okay, 7.21 decrease means acidosis. The PCO2 is 30 mmHg. The 35 to 45 is the normal range, so PCO2 decreased. And the bicarbonate is 14, so bicarbonate is also decreased. Bicarbonate is also decreased. Now see, There is Kussmaul breathing. This is hyperventilation. This is the compensatory mechanism for the metabolic acidosis. So the disease which goes with the pH is the primary defect. So there is decrease in the pH means acidosis, and bicarbonates is decreases means acidosis. So metabolic acidosis, those who goes with the pH is the primary defect. So here metabolic acidosis, here acidosis. So it is metabolic acidosis, and there is compensation with the help of hyperventilation. So hyperventilation will blow out the CO2 and decreases the carbonic acid level to maintain the bicarbonate and carbonic acid ratio to 20:1. So that so this is answer here is the metabolic acidosis. Metabolic acidosis is the answer with compensation. If it is in the option, it is the better choice. Metabolic acidosis with compensation. Here when there is increased ketone body production, so ketone bodies, so acetoacetic acid, beta hydroxy, butyric acid, these are the acids, and to neutralize these acids, this bicarbonate is utilized. That's why there is metabolic acidosis in diabetic ketoacidosis, and it is a cause for high anion gap metabolic acidosis. So remember, diabetic ketoacidosis is very, very important, and you should be able to answer the these conditions that are these acid based disorders. So remember that in acidosis pH will be less than 7.35 means acidosis, और pH के साथ जो पैरामीटर जाएगा that is the primary defect. मतलब बाइकार्बोनेट अगर डिक्रीज होता है तो मेटाबॉलिक एसिडोसिस, अगर PCO2 बढ़ता है तो रेस्पिरेटरी एसिडोसिस. मतलब जो pH के साथ जाएगा वो प्राइमरी डिफेक्ट, और दूसरा जो पैरामीटर है वो कॉम्पेंसेशन है. दूसरा जो पैरामीटर है वो कॉम्पेंसेशन है. समझ में आया क्या? सी पीएच के साथ जो जाएगा, पीएच डिक्रीज मतलब एसिडोसिस, और पीएच के साथ अगर बाइकार्बोनेट डिक्रीज होता है तो मेटाबॉलिक एसिडोसिस. अगर पीएच के साथ पीसीओ2 जो है वो बढ़ा हुआ रहता है, दिस इज रेस्पिरेटरी एसिडोसिस. सो दिस इज रेस्पिरेटरी एसिडोसिस. दूसरा जो रहेगा वो कॉम्पेंसेशन रहेगा. तो यहाँ पे रोथराज टेस्ट इंपॉर्टेंट है. रोथराज टेस्ट डिटेक्ट एसिटोएसिटेट एंड द acetone, but it is not for the beta hydroxybutyrate. It is a false ketone body. It contains hydroxyl group, do not contain the ketone group, but it is produced in the ketone body metabolism. Which of the following enzyme activities is used to diagnose vitamin B2 deficiency? B2 पूछा है, राइबोफ्लेविन पूछा है. क्वेश्चन एक बार फिर से पढ़ने का. ओके, नाउ सी here answer is glutathione reductase. Transcytolase, it is for the B1. RBC transcytolase activity, it is for the thymine, to know the thymine status of the body. Glutathione reductase for the B2. The following is due to deficiency of, this is Bitot spot, triangular white opaque spot on the conjunctiva. So it is due to vitamin A deficiency. Retinal is the form of the vitamin A which is required for the vision. It is present in the rhodopsin. It is present in the rhodopsin. 11-cis retinal is the form which is present in the rhodopsin. So and beta carotene is having the antioxidant property in the vitamin A. Also the RDA of vitamin A is important, that is 600 microgram for adult, and it is that is 800 in pregnancy and 950 microgram in the lactation, vitamin A requirement. The next question is, a 13-year-old boy was brought to the clinic with jaundice, fatigue, muscle stiffness, tremor and behavioral changes. Jaundice, liver involvement, fatigue, muscle stiffness, tremors and behavioral changes means neurological involvement is there. Examination revealed an enlarged liver and spleen. Kaiser ring was noted. So Kaiser-Fleischer ring is the characteristic of which disorder? It is a characteristic of Wilson's disease, KF ring. The golden brown ring around the descendant membrane of the cornea is the feature of the Wilson's disease. It is cerebrohepatorenal disease in which there is liver is involved. Then the tremor and behavioral changes means neurological manifestations are there. It is a condition where copper excess occurs. It is because of mutation in the gene, that is a protein, that is ATP7B. So A comes first and M comes first. ATP7A Menkes disease. 7A, A comes first, so Menkes first. ATP7A Menkes disease, ATP7B Wilson's disease. दोनों का एक ये है, just बताता, just wait. हाँ, So say ATP7A is required for the intestinal absorption of the copper. If there is defect in the ATP say 7A, so the copper absorption decreases, ceruloplasmin level decreases. So it causes Menkes disease. While ATP7B mutation, ATP7B is required for the excretion of copper from the liver to bile. Liver to bile. So the copper accumulates in this disease. Copper accumulates, but also it is required for incorporation of copper into the ceruloplasmin. So ceruloplasmin level decreases in the Wilson's disease. So there is copper accumulation in the liver, in the brain. So in the brain, it is known as hepatolenticular degeneration. So there is involvement of liver, there is involvement of lenticular nucleus of the brain in the Wilson's disease. Also it causes the sunflower cataract in the lens. Next question, which of the following is a cytochrome complex 4 inhibitor? So it is very easy question. Complex for all gases. Here answer is the cyanide. लेकिन यहाँ पे mixing कहाँ पे होता है? C, carbon dioxide is there. It is carbon monoxide which inhibit the complex 4 of electron transport chain. So it is inhibited by carbon monoxide. It is inhibited by the cyanide. It is inhibited by the hydrogen sulfide, and one more is there: cyanide, carbon monoxide, hydrogen sulfide and azide. These are the inhibitors of complex 4 of electron transport chain. ये topic तो पूरा आपको prepare करके रखना पड़ेगा. So these are the inhibitors of complex 1, that is pyridine, amobarbitol and rotenone. These are the inhibitors of complex 2, that is the malonate and this TTFA and carboxyl. These are the inhibitors of complex 2. Complex 3 inhibitor includes the antimycin, British anti-leviside and the fenformin. And the complex 4 inhibitor includes cyanide, carbon monoxide, hydrogen sulfide and azide. These are the gases which inhibit the complex 4 of electron transport chain. Then comes the uncoupler. See, uncoupler का mechanism of action क्या है? Due to continuous pumping of protons. See, normally due to continuous pumping of protons, that is 4 from the complex 1, 4 from the complex 3 and 2 from the complex 4, there is protons on the in the intermembrane space that gives the positive charge to the outside of inner mitochondrial membrane, and inner side now becomes the negatively charged. So there is development of proton gradient, and through this FO complex, this flux of protons will be there from this O unit, FO unit of the ATP synthase. So that will rotate the gamma handle, and that causes the conformational change in the beta unit that results in the ATP formation. So this is chemiosmotic hypothesis. So what is the role of uncoupler? Uncoupler increases the permeability of this membrane and does not develop, the proton gradient will not develop. So what is mechanism of action of uncoupler? It increases the permeability of inner mitochondrial membrane. Now see, these are the chemical uncouplers: 2,4-dinitrophenol, dinitrocresol, fluorochlorocarbonyl phenylhydrazine, and aspirin in high doses. Also the thermogenin, thyroxine, long chain free fatty acid and unconjugated bilirubin. These are the uncouplers. Also there is potassium ionophores, which increases the movement of potassium across the membrane and disrupt the gradient. So it is valinomycin, gramicidin and nigrosin. So these are the MCQ. This is important now. Valinomycin, gramicidin and nigrosin, potassium ionophores, they disrupt the gradient, electrochemical gradient across the inner mitochondrial membrane. So oligomycin and venturicidin inhibit the FO subunit. F1 subunit, it is inhibited by the arovertin, and ATP ADP transporter, it is inhibited by the atractyloside. So this chart is very important. This chart is from the Leninger textbook of biochemistry. So this is important, very important. Okay. Now see, a 3-year-old child presented to the OPD with difficulty in vision. So vision is affected here. On fundus examination, cherry red spot. See, whenever there is cherry red spot, think about the first thing in your mind should be lipids, that is sphingolipidosis. Okay. So on fundus examination, cherry red spot were seen on the macula. There was not organomegaly. So organs are not involved. The most likely diagnosis would be, ये हमने अभी डिस्कस किया था. हमने बोला था कि चेरी रेड स्पॉट विथ नो ऑर्गन इन्वॉल्वमेंट इज टिपिकल फॉर विच डिसीज? Cherry red spot with no organ involvement. Here answer is Here answer is, it is Tay-Sachs disease. No organs are involved because of defect in hexosaminidase A. Okay, Hunter disease, it is mucopolysaccharidosis with clear cornea. Gaucher's disease, it is crumpled tissue paper appearance. There is no cherry red spot in the Gaucher's disease. Thrombocytopenia, pancytopenia is there. Erlenmeyer class deformity will be there. Niemann-Pick disease, hepatosplenomegaly, cherry red spot on the macula. So here organs are involved in the Niemann-Pick disease. GLUT4 is insulin dependent glucose transporter present in the GLUT4 insulin dependent glucose transporter. It is present in skeletal muscle, heart and adipose tissue. Also GLUT8 and GLUT12, they are insulin dependent. On the basolateral surface of intestinal mucosal cell, liver, sinusoidal surface of the liver, beta cells of the pancreas, it is GLUT2. It is GLUT2. Placenta, kidney, RBC, colon and brain. So this is mnemonic for the GLUT1. Widely distributed GLUT1. Kohli plays for RBCs. So Kohli plays for RBCs. So placenta, kidney, RBC, colon and brain. And the small intestine. GLUT5, it is present in the small intestine. Also SGLT. SGLT, it is present in the small intestine. SGLT1, it is present in small intestine and renal tubule, and it is major transport form of the glucose. It is required for the transport of glucose and galactose. So sodium dependent glucose transporter, SGLT1. SGLT2 is present in the renal tubule. SGLT2, this is major transport form of the glucose for the absorption of glucose in the intestine. GLUTs, these are the types of facilitated diffusion. GLUT1, it is distributed in the brain, kidney, colon, placenta, RBCs and retina. It is important for the basal glucose uptake. GLUT2, it is present on the sinusoidal surface of the liver, basolateral surface of intestine, basolateral surface of proximal convoluted tubule and pancreas, beta cells of the pancreas. GLUT2, it is important for the regulation. Important for the regulation of blood glucose level. GLUT4, it is insulin dependent glucose transporter present in skeletal muscle, heart and adipose tissue. GLUT5, 5 fructose facilitated diffusion. So fructose is absorbed by the facilitated diffusion with the help of GLUT5. And GLUT7, it is important in the liver endoplasmic reticulum, where it is important for the transport of glucose in the endoplasmic reticulum. Okay. The next question is, a patient presented with pleural effusion, bilateral crepitation were felt in the lungs. The diagnosis of congestive high output cardiac failure was made. The most likely vitamin deficiency in this child would be, now see here, vitamin B12 deficiency causes megaloblastic anemia, also subacute combined degeneration of spinal cord. Vitamin C deficiency causes scurvy. Vitamin B6 pyridoxal phosphate deficiency causes neurological manifestation because it is associated with the neurotransmitter synthesis. Now vitamin B1 deficiency causes beriberi. So beriberi, there are three types of beriberi: dry, wet and the infantile beriberi. So in dry beriberi, there is neuropathy, neurological manifestation, neuropathy in dry beriberi. While in wet beriberi, there is cardiac symptoms, there is edema, there is pleural effusion, there is pericardial effusion, there is high output cardiac failure because of peripheral vasodilation. In thiamine pyrophosphate deficiency, there is high output cardiac failure and raised blood pressure. Remember this word, high output cardiac failure in wet beriberi. So this is a case of wet beriberi due to thiamine deficiency. Remember, thiamine is very, very important because it is related with the dry beriberi that causes the neuropathy. Then wet beriberi, which causes the cardiac symptoms, the pericardial effusion, pleural effusion, high output cardiac failure. Then the edema, it is symptom. These are the symptoms of wet beriberi. Then infantile beriberi, there is severe manifestation. And the Wernicke-Korsakoff syndrome in chronic alcoholic, there is the symptoms, that is the GOVA-MP in the B1 deficiency, that is global confusion, ophthalmoplegia, ataxia, then memory loss and psychosis. These are the features of Wernicke-Korsakoff syndrome in B1 deficiency in chronic alcoholic. So this is the case of wet beriberi. A 7-year-old child was brought to the OPD with history of dermatitis. See, dermatitis मतलब पहला चीज आता दिमाग में niacin. Now read again. Thin hair, niacin nothing to do with the thin hair, and the alopecia. So alopecia का दिमाग में आया तो alopecia is there इन द जिंक डेफिशिएंसी. ओके, अभी हमारे पास जिंक है, नियासिन है, और नाउ द dermatitis, thin hair and alopecia, it is symptom of one more vitamin. The dietary history revealed that kid was consuming raw egg. यहाँ पे पूरा क्लियर कर दिया, raw egg consumption which contain avidin. Okay, so for long time, which of the following deficient in this child? So it is biotin deficiency. So raw egg consumption causes the biotin deficiency. Biotin is associated with the dermatitis and alopecia. Remember, diarrhea, alopecia, dermatitis. Diarrhea, alopecia, dermatitis, zinc deficiency. Diarrhea, dementia, dermatitis, niacin deficiency. And here the dermatitis, thin hair, alopecia along with history of raw egg consumption, it is biotin deficiency. A patient with low insulin glucagon ratio, मतलब low insulin level, which of the following enzyme will be stimulated? So remember the hormone sensitive lipase, it is stimulated by the glucagon. It is hormone sensitive lipase. Remember, insulin favors the, it is anabolic hormone, insulin anabolic hormone. It favors the dephosphorylated state, and dephosphorylated state, which are the enzymes which are active in the dephosphorylated state? The glycogen synthase, HMG coenzyme A reductase, lipoprotein lipase. These are the, this is promoted by the insulin. Here low insulin means low insulin and high glucagon, so it is promoted. Lipolysis, it is promoted by the hormone sensitive lipase, that is by the glucagon. A young child presented with history of rashes, again there is dermatitis, rashes around the eye and the mouth. The mother complained of impaired night vision in the child. Night vision impaired हो गई, मतलब विटामिन ए से कनेक्टेड है. Okay, and also complained that the child fell down last month and the wound healing was not proper. Wound healing, improper wound healing, it is connected with vitamin C, hyaluronic acid and zinc. वुंड हीलिंग बोला तो तीन चीजों के बारे में सोचने का. एक विटामिन सी, स्कर्वी which causes delayed wound healing, then hyaluronic acid, and third one is the zinc. Which of the following would be deficient? Now see here, there is rashes around eyes and mouth, that is known as acral dermatitis. Okay, the mother complained of impaired night vision. Vitamin A activity in the serum is maintained by the zinc. Zinc is required for maintaining the vitamin A activity in the serum. So here answer is zinc. So deficiency of zinc causes the acrodermatitis enteropathica, in which acral part of the body, mouth, nose, perineal region, the toes and fingers, they are involved. So there is rash in the zinc deficiency, and remember that whenever there is diarrhea, alopecia, dermatitis and delayed wound healing, it is a case of zinc deficiency. It is a case of zinc deficiency. Copper deficiency causes Wilson's disease, Menkes disease, also causes the anemia. Okay, selenium disease defect causes the cardiomyopathy. No disease is related with the cobalt. It is related with the B12 cobalt. Which of the following will be biochemical basis of gum bleeding in the scurvy? Gum bleeding in the scurvy. So it is scurvy, it is impaired collagen synthesis. Vitamin C has role in collagen synthesis. Collagen, most common amino acid is glycine, followed by the proline and hydroxyproline, then lysine. These are the most common amino acid. So for the collagen synthesis, the hydroxylation of proline means hydroxyproline synthesis and hydroxylysine synthesis. For hydroxylation of peptidyl proline by the prolyl hydroxylase, and for hydroxylation of peptidyl lysine by the lysyl hydroxylase. This is post-translational modification. For this activity, the vitamin C is required. Vitamin C is required. So vitamin C is required for the collagen synthesis, and for the cross-linking, lysyl oxidase enzyme is important, which is copper dependent. Okay, so remember that impaired collagen synthesis in the scurvy, gum bleeding in the scurvy. Now coming to the next question, see, मैंने बोला था ग्लाइकोजन स्टोरेज डिसऑर्डर पे क्वेश्चन रहते हैं, और ये टॉपिक अच्छे से करना, पूरा वोनगर्ग डिसीज, पॉम्पेज डिसीज, मैकार्डल डिसीज और ग्लाइकोजन का रेगुलेशन. ओके, डिफॉस्फोराइलेशन, फॉस्फोराइलेशन और कैल्शियम का रोल, ये इतना करके जाना अच्छे से। A 7-year-old child was brought to the OPD with complaint of excessive fatigue and muscle pain after playing in the school. Fatigue and muscle pain after playing in the school. Blood investigation were done immediately after the exercise, and the result revealed excessively increased lactate level. It is not increased lactate level, it is low lactate level. Low lactate level. What is most probable diagnosis in this child? Remember, ऐसे का ऐसा सेम हार्पर में सेंटेंस दिया है. There is muscle pain and fatigue after the exercise with low lactate level and low glucose level. It is a case of low lactase and low glucose level. Muscles are involved here. So with complaint of excessive fatigue and muscle pain after the playing. So it is low lactate level after exercise. Yes, this is a sentence from the Harper's textbook of biochemistry. So it is a McArdle disease. Cory's disease, there is limit dextrin accumulation occurs in the Cory's disease. There is involvement of muscle, there is somewhat involvement of liver occur, and the progressive liver cirrhosis is there in the Cory's disease. In von Gog's disease, the protuberant abdomen, hepatomegaly, renomegaly is there. There is deficiency of glucose 6 phosphatase, and there is increase in the uric acid level occurs in the von Gog's disease. Also there is hyperlipidemia in the von Gog's disease. Means uric acid, hyperlipidemia, lactic acids, they are involved. Hepatomegaly, renomegaly should be there for the diagnosis of von Gog's disease. Pompe's disease, it is muscle, they are predominantly involved. There is hypotonia in the Pompe's disease, and there is cardiomegaly, and death due to cardiac arrest occur in the Pompe's disease due to the lysosomal acid maltase defect in the Pompe's disease. So it is also a lysosomal storage disorder, Pompe's disease. Muscles are affected in the Pompe's disease, and death occur in 18 months to 2 years of the age because of involvement of heart. Cardiomegaly is there in the Pompe's disease. Also tongues are involved in the Pompe's disease. So here disease, the answer is McArdle's disease. A 7-year-old child was brought to the OPD with complaint of easy fatigability. The mother also complained that kid was active after a meal and was extremely hungry and tired in between the meal. In between the meal. Okay. The liver biopsy revealed no glycogen. So no glycogen. Okay. Accumulation. What would be the most likely enzyme deficient in this child? So see, these are the options for the glycogen storage disorder, but the hint is there. There is no glycogen accumulation. This occurs in glycogen synthase deficiency. This occurs in glycogen synthase deficiency. No, liver biopsy shows no glycogen accumulation, but the life expectancy is less in case of glycogen synthase deficiency. Okay. See, branching enzyme, debranching enzyme, the symptoms are quite there is accumulation of compounds, accumulation of glycogen in all these three, but there is no accumulation of glycogen in the glycogen synthase defect. So here answer is glycogen synthase, that is type 0 glycogen synthase defect. So in between the meal there is fatigue, weakness, and there is no glycogen accumulation. This is also the first symptom that is given in the Harper's biochemistry. Okay, see, type 0 glycogen synthase defect, no hepatomegaly, hypoglycemia in between the meal. Von Gog's disease, there is hepatomegaly, there is renomegaly, renal tubule involvement is there, and there is hyperlipidemia is there, hyperuricemia is there, and lactic acidosis is there in the von Gog's disease. In the Pompe's disease, there is involvement of heart, there is involvement of tongue, and muscles are involved. There is hypotonia in the Pompe's disease. So glycogen accumulation in liver and heart occurs. Cory's disease, so limit dextrin accumulation is there. So A, B, C, D. Anderson disease, branching enzyme defect. Cory's disease, debranching enzyme defect. So Cory's disease, limit dextrin accumulation is there, and in this both Cory's and Anderson disease, livers and muscles both are affected, and there is liver enzymes, they are deranged. There is increased level of SGOT, SGPT in this type 3 and type 4. In the McArdle disease, muscles are involved. There is second wind phenomenon, means if you take rest for some time, you can resume your activity, and if you continue your exercise, there may be passage of burgundy colored urine on severe exercise due to deficiency of muscle phosphorylase. This is frequently asked question on McArdle's disease. exercise intolerance, and muscle glycogen phosphorylase defect. Host disease, liver phosphorylase is defective, hepatomegaly, and fasting hypoglycemia is the feature. Now next one is the identify the vitamin deficiency responsible for condition depicted below. Now see this. See this. So it is, which vitamin is deficient? A, nothing to do with the bones. Vitamin E and vitamin K, nothing to do with the bones. So it is a ricket. So there will be increase in the alkaline phosphatase level, low vitamin D activity, low vitamin D stores. So that causes the rickets. So there are symptoms developed according to the age. At the crawling, when the infant start crawling, the widening of the wrist occur. When he start walking, due to weight bearing joint, it get bored because of spongy bones, because of decrease in the vitamin D activity. So this is the case of rickets. So PDF of this lecture will be uploaded on the PW Meded Telegram channel, and this is a QR code for the Meded channel. So thank you very much, all of you. Thank you very much.